I did.
Mostly filtered our way into the room here, so we'll go ahead and get started. It's my pleasure to introduce our speaker, Dr. Anna Fashandi. As some of you here know, the person being introduced frequently provides a bio to serve as fodder for the introduction. In this case, I think it's fair to say that at the very least, Dr. Fashandi and I are complicit in this content. So here you go. Most of you know Anna Fashandi, but for those who do not, she is a Virginia native and a quadruple hoop, having completed undergrad, medical school, and residency here at UVA before joining the faculty. She completed residency in 2020, finishing in the top 5 of her chief class. She then moved to a terrible COVID race during the height of the pandemic, so don't ask her to describe all the fun things to do in Ann Arbor she doesn't know. At the University of Michigan, she completed the renowned Norm Thompson Endocrine Surgery Fellowship, and when we could finally post an endocrine surgery position here, she applied and has been on the faculty since 2022. A few fun facts about Dr. Fashandi. She is married to Ahmad and now considers herself an amateur Afghan cook. She has 2 daughters, Pippa and Fiona, both of whom were born during her residency, and in fact, the last grand round she gave when she was the chief resident on the topic of being a parent during residency. She is a loving and supportive mom, but does not hesitate to disqualify her children when she is a strokes and turns judge at their swim meets. She loves animals and has 2 dogs that may or may not drive her family to financial ruin with their maladies. And finally, she makes a mean whiskey sour and generally is much like her favorite drink, at times biting, but balanced with sweetness. In all seriousness, having Dr. Fashandi as my partner has been a true source of personal joy for me. She's been an invaluable asset to me, to our patients, and to the department since joining us. Among the things that we were looking for when we were recruiting her for this position was to establish a program in interventional thyroidology. She's achieved this with persistence and professionalism. I look forward to what she has to share on this topic. Dr. Fashandi.
Good morning. Thank you for inviting me to speak. As Dr. Smith said, this is my second grand round here because I had the honor as a chief resident just over 5 years ago. At that time, I think we were allowed to have about 10 people in this room, and everyone was really spread out because of COVID restrictions. So I'm crushing my in-person attendance right now. So pretty good about that. Today, I'm going to talk about interventional thyroidology, which is a term that encompasses all of the minimally invasive, non-surgical techniques that are currently available to treat thyroid pathology. As a quick background, since part of the idea of having junior and newer faculty members give grand rounds is so the department can get to know us better, I'll give you a quick version of my story, even though Dr. Smith gave you some of the basics. I grew up mostly in Richmond, was born in New Hampshire during my dad's surgical residency. I spent most of my childhood, teen, and college years wanting to be a veterinarian. Now, prepare yourself for the most unhinged AI image ever that I created, because I don't have any pictures of me back in my veterinary days, or pre-veterinary days. But I wanted a picture because I knew that I was going to be a zoo veterinarian. I was going to operate on elephants and tigers. That was like my dream. Sorry for her terrifying smile. Everything about it creeps me out. It's back. But when right after I graduated from college, I had a very Tiger King-esque experience. I worked in Texas at a sanctuary for big cats, taking care of, I think it was 66 cats at the time. At that point, that's actually where I decided, you know what, I'm going to do medicine because it turns out I'm a little bit more of a people person than a lot of people in exotic animal medicine. So I made the switch. I applied to medical school, came back here, met my husband on my first day of medical school. We graduated. We're lucky enough to both stay here for residency. And then after that, during residency, this is my chief class in our COVID masks up on the helicopter pad. Let's see. After that, or during residency, I had 2 daughters. They are crazy and love soccer, and they are the light of my life. We then all moved to Michigan for a year, which, as we said, not the best in the pandemic, but it was a really great year, a lot of independence, and kind of taught me how to operate on my own. And then eventually made it back home to Charlottesville. I used to joke with Dr. Smith that one day we would be partners. Didn't think it would actually ever happen, but when the job opened up, I was thrilled to be able to come back and have officially been here for 3 years as of last week. Listening to the other recent faculty lecturers, including Adana and Matt, I was really jealous that I don't have really exciting or poignant or inspiring talks to give. But I hope that you'll at least learn something new. And I don't know, maybe later in my career, I'll have more life parts as well. I have no financial disclosures, but I do feel the need to disclose that while I have experience in the main techniques I'm going to talk about today, I only started doing these last year, and I've only had 8 patients actually choose to do radiofrequency ablation so far. So I'm certainly not the best person in the world to talk about it. But the reason some of those numbers are low is just there's a lot of factors that kind of go into it. Sometimes referring physicians don't even know it exists or don't know my ability to offer it here at UVA. There are financial concerns because insurance companies don't always cover all of it, and it can be an over $5,000 out-of-pocket expense for a patient. So lots of people are chased away because of that. And then in addition, some patients, even though they want it, are just there's anatomic constraints that don't allow them to be good candidates for it. Today, I'm going to try to familiarize everyone with the main techniques that are offered, explain the indications of the 2 that I perform, which are ethanol ablation and radiofrequency ablation, or RFA. I'm going to review some outcomes of the procedures, and finally, we'll look kind of at expanding indications and opportunity for growth in these techniques. Also, given my love of animals, I'm going to pepper in some random animal facts just to keep you awake and at least mildly entertained. So we'll start there. There are not many cool animal thyroid facts. I did look. So most of these will not be relevant in any way to this talk. But did you know that parathyroids were discovered in the rhinoceros? Yeah, that I did know. But what I didn't know is that they are thought at this point to have derived from the gills of our fish predecessors, our ancestors before they came to land, which I had no idea about. Just learned that in the last few days. As some background, thyroid nodules are really common. About 50% of adult females have them, 30% of adult males. Thankfully, the vast majority are benign and cause no symptoms. But after a benign biopsy, they can be observed and potentially serially followed, never needing any intervention. There are still many patients who do experience symptoms, though, including cosmetic concerns, compressive symptoms from large nodules, or subclinical or overt hyperthyroidism. These symptoms lead to referrals for definitive treatment, and in much of the country, these symptomatic patients aren't offered any non-surgical treatments since there are few experienced practitioners of minimally invasive techniques. This is despite the fact that some of these techniques have been around for almost 20 years now. Symptomatic benign nodules often are treated with lobectomy, while hot nodules causing hyperthyroidism can be treated surgically or with radioactive iodine or antithyroid meds. Low-risk cancer, meaning small, less than a centimeter papillary thyroid cancers, can be treated surgically or with active surveillance, where we just watch them over time and assess for growth and change. There are drawbacks to all of these potential treatments, though. Lobectomy has a high associated cost, a 30% risk of post-op hypothyroidism requiring hormone replacement, and surgical complications, including recurrent or superior laryngeal nerve injury, and it also obviously causes a scar. Radioactive iodine can and often does lead to hypothyroidism. It affects women who are thinking about family planning and trying to get pregnant. And there are also theoretical concerns about fertility issues and secondary malignancy because of the radiation. Antithyroid medications rarely lead to remission of hyperthyroidism in autonomously functioning nodules. So they're pretty much a lifelong medicine. They're teratogenic, and they also have very serious side effects, including agranulocytosis, hepatotoxicity, and vasculitis. And finally, for low-risk cancers, while avoiding, I'm just realizing this box is going to show up here. For low-risk cancers, while avoiding surgery and opting for surveillance seems great, you don't have to have surgery, it's a lifelong pursuit and can cause a lot of patient anxiety because every year the patient's just waiting to hear if their cancer has grown or spread. So with that in mind, that just skipped. Although they're not offered everywhere, there are multiple non-surgical ablative techniques used for the treatment of thyroid nodules. Broadly, they're divided to chemical ablation and thermal ablation. Ethanol ablation is the lone chemical ablation, and it's been around for a while, but thermal ablation has been more recently superseding its use for thyroid nodules. As we'll see later, these techniques are effective in accomplishing the goal of nodule shrinkage and improvement in local symptoms. And importantly, they address many of the concerns the other available treatment options that we just talked about have concerns with. First, they're office-based. They don't require any anesthesia or hospitalization. They cause no scar and have very low risk of causing concerning complications, including nerve injury or hypothyroidism. And they're therefore less likely to delay family planning or affect fertility. The ablation techniques we're going to discuss today are used throughout the world, and their use has been growing in the US over the last several years. The initial use of RFA for thyroid nodules was in South Korea, and the first paper describing it was published there in 2006. The adoption of RFA in the US has been fairly slow, however, and there are several reasons for that. First, the FDA didn't approve it for use in soft tissue nodules until 2018. By 2019, only 13 programs existed in the whole country that offered RFA. And then in 2020, with COVID, there were limited opportunities to observe, teach, or trial its use. And there were no hands-on courses or expert proctoring during the pandemic. In 2022, the North American Association of Interventional Thyroidology was founded and dedicated to advancing the field. This map is from a 2022 paper by Jen Kuo. She's an endocrine surgeon at Columbia and was one of the earliest adopters of RFA in the US. You can see that as of 2021, there were not many providers offering this procedure, only 37 centers in the entire country. On this map, there are only 4 distinct locations or practitioners within a 200-mile radius of Charlottesville. And the one Virginia program was actually a previous IR physician here who left before this paper was published. Although I don't have an updated map to show where this procedure is offered in 2025, I did recently just do a search for providers within 200 miles of Charlottesville. And this is the 11 people, including myself, who offer it. I expect the trend's pretty similar in most places. Then there are now in NASIT 116 members that nationwide that say that they do it, but I'm sure there are many people who are offering it that are not members of NASIT. You can also see that there are a variety of different practitioner types offering this procedure. So there are surgeons, including endocrine and ENT surgeons, and IR physicians. They're the most common. But in some places, this is actually offered by endocrinologists and PCPs. I was trained by an endocrinologist in Michigan. I went up there to do a training session, and he does tons of these. So it is not just surgeons. Before I cover the interventional procedures, I just wanted to quickly review the anatomy, which is relevant to thyroid surgery and minimally invasive thyroid ablation techniques, particularly for the more junior audience members. As I'm sure most of you can tell, this is an axial view of the thyroid in red with the trachea in white. The recurrent laryngeal nerves, can you see my pointer now? The recurrent laryngeal nerves innervate most of the muscles of the larynx and are shown in yellow just lateral to the trachea on either side in that triangle. The esophagus is this white structure on the left-hand side, well, patient's left, right-hand side of the screen. And then the common carotid and the internal jugular veins are embedded laterally on both sides. The structure we most worry about during thyroid and parathyroid surgery is the recurrent laryngeal nerve, because unilateral injury can cause transient or permanent voice changes, dysphagia, or aspiration issues. The structure is not at risk from surgical dissection in these techniques that we're going to talk about today, but they are at risk for both chemical and thermal injury, which results in the exact same issue. The so-called danger triangle, which includes the recurrent laryngeal nerve and the esophagus, is what people worry most about when learning how to do this procedure. But the point of this slide is also to point out all the other areas that there is danger. So if you look at the yellow A on the left-hand side of the screen, that is the area where the vagus nerve lives. That is not something that's really at risk during thyroid surgery, because it's usually kind of retracted out to the side during our dissection, but in its native anatomic location, it's right next to where the thyroid is and potentially where the nodule is. So it definitely can be injured. The problem with that is that it is what the recurrent laryngeal nerve is a branch of, so it presents the same way with hoarseness and other issues from recurrent laryngeal nerve injury. Letter B represents an area where a posterior tracking vagus or a cervical sympathetic ganglion can be injured by thermal spread, the latter of which can result in ipsilateral Horner syndrome. C is an area just posterior to the thyroid. That's where a non-recurrent laryngeal nerve or a more oblique course of the recurrent laryngeal nerve can be injured as well. And then finally, any area posterior to the thyroid is at risk for a thermal injury to the trachea. All of that is just to say you have to be really aware that there are lots of potential pitfalls of this procedure, and that's why it does make me a little nervous that other people are doing this that maybe don't have as great of a concept of the relevant anatomy. Does anyone know what this pretty guy is?
Mantis shrimp.
Mantis shrimp, perfect. So they are incredibly fast. They're so fast that their claws can move faster than a .22 caliber bullet. And so the scientists that study them have to keep them in really thick plastic tanks because they have been known to shatter glass tanks, which I thought was pretty cool. Also, they're really beautiful. Moving on. Ethanol ablation. All right, so the first interventional thyroid procedure we're going to talk about is the alone chemical ablation. Ethanol ablation is most commonly performed on cystic thyroid nodules using dehydrated 95 to 99% ethanol. It's an outpatient procedure. It's really quick. It takes about 10 minutes to do one of these. You use ultrasound guidance and drain the cyst first, and then add in dehydrated ethanol slowly. It is allowed to dwell for several minutes, and then we re-aspirate it after the dwell time. So some practitioners do choose to leave it in situ. It works by causing coagulative necrosis via cell dehydration, as well as ischemic necrosis via small vessel endothelial damage and thrombosis. The idea is that you kill all the cells kind of surrounding the cyst so that it can't make fluid anymore and reaccumulate. This picture just shows an example of the results of a sizable cystic nodule before and after the procedure with a really excellent response. The nodule started at 17.6 mLs, had an almost 80% increase just a month later, and then the last frame shows that it's essentially gone. The main complication of this procedure is leakage of ethanol from the nodular cyst after you put it in, and that can cause severe pain. It can also cause hoarseness if it affects the nerve. That's the main reason that I choose to re-aspirate it, because I don't like the idea of it being able to leak out after the patient has gone home. That seems like something that's easy to avoid, so I do it. In terms of outcomes, ethanol ablation has been shown to be really effective in treating cystic as well as some solid lesions with a 38 to 98% volume reduction and significant improvement in local symptoms. Results are best, about 85 to 95% reduction in mixed cystic nodules and worst in solid nodules. They only can achieve about a 30 to 40% volume reduction. Importantly, the positive effects of ethanol ablation persist even up to 5 years after the procedure, with 86% of patients still with significant volume reduction and over 90% improvement in their symptoms. There has been some recent investigation in the use of ethanol ablation in low-risk papillary thyroid cancer, or PTC. One study was done at a single center in with 15 patients and 17 tumors. They received injections on 2 successive days. 47% of those tumors completely resolved, and the median volume reduction was 80 to 90%, with no new cancers or nodal mets at 5 years. Several factors have been identified which negatively affect the expected results after ethanol ablation, including a high number of prior attempted interventions, increasing size and vascularity of the nodule, as well as the presence of multiple loculations within the cavity. Although thermal techniques can be used, often in combination with ethanol ablation, this is clearly the preferred procedure for completely cystic nodules, as it's easier and cheaper to perform than the other ablative techniques. In solid nodules, its use is more limited because of the need for multiple treatments to achieve the desired effect. Okay, so this just summarizes society recommendations for its use. In their guidelines for the management of adult thyroid nodules and differentiated thyroid cancer, the American Thyroid Association, or ATA, supports the use of ethanol ablation for benign cystic nodules causing compressive or cosmetic concerns. They recommend that first, it be aspirated with cytology to confirm that the nodule is indeed benign, and then it can be followed with ethanol injection if the lesion recurs after simple aspiration. In their updated 2025 guidelines, which just came out about a month ago, carefully selected patients with early stage PTC without evidence of nodal or distant mets can be treated with ethanol ablation for the ATA. European Thyroid Association released guidelines in 2020 and similarly recommends this procedure for cystic nodules, but they recommend against its use in papillary thyroid cancer, mostly in favor of the other thermal techniques that we're going to talk about later. All right, so now we're going to move on to thermal ablative techniques. These are used for more solid nodules, and then there are several options. I'm going to focus on RFA later, since that's what I do, and it's the best studied. But I'll briefly describe the other thermal ablative techniques just so you know what they are. The first thermal ablation procedure is high-intensity focused ultrasound. Of note, this is the only procedure that is truly non-invasive. No needle has to be inserted for the treatment of these thyroid nodules. I don't believe there's anyone here in radiology offering this procedure. I've talked about it with Dr. Brennan briefly in the past since he's been using it in the breast world, but I don't think we offer it here. HIFU uses acoustic energy delivered by an ultrasound to cause molecular vibration and generation of frictional heat to the target tissues. As the temperature climbs, microbubbles form, expand, and collapse, causing hemorrhage and cavitation of the nodule. This is all delivered through a cooled probe that works both as a diagnostic ultrasound and to deliver the generated acoustic energy. It's delivered in a semi-automated fashion and based on a computerized mapping model, which helps protect the skin, trachea, large vessels, and other nearby structures. So this picture shows the nodule that's going to be treated in box A. This is just an ultrasound. The areas in red represent areas outside of the safety margin due to their proximity to the trachea and the recurrent laryngeal nerve. Box B shows the computerized schematic showing the areas of intended treatment in white and then the excluded sites in red. After they receive an ultrasonic pulse, the white areas sequentially become green, mapping the progress of the procedure. The side effect most commonly experienced during this procedure is pain, which can actually be pretty problematic because the procedure takes a fairly long time, and the discomfort and resulting movement of the patient can interfere with the mapping and safe delivery for ultrasound. So local anesthesia or even monitored anesthesia care is required to keep patients comfortable and prevent them from moving. Major complications are really rare with this, but it is possible to injure nearby structures, as we talked about. And importantly, it can't be performed on cystic structures because the fluid component interferes with the delivery of acoustic energy. Cryoablation is the one thermal procedure that induces tissue necrosis via cooling the target tissue. It's uncommonly used, and from what I've seen in relation to thyroid pathology, it's mostly just for metastatic disease to lymph nodes, bone, and lung. This picture shows an enlarged cervical lymph node in a patient with metastatic thyroid cancer in box A and B. During the procedure, pressurized gas, typically argon, is introduced via a needle probe to the target tissue, as shown in box C. And then the gas expands and causes rapid cooling in the formation of an ice ball, which destroys the nodule. Ice balls are not well seen on ultrasound, so these usually require CT or MRI to monitor the procedure. It causes osmotic insult, cell wall crystallizing injury, as well as microvascular thrombosis. And it causes less tissue disruption than other thermal ablation techniques, possibly because, with possible lower risk of vascular or nerve injuries. Box D with the red circle just shows that lymph node is now completely disappeared. The last three thermal procedures are microwave, laser, and radiofrequency ablation, and all are quite similar. I'll quickly cover microwave and laser ablation together. Microwave ablation uses a microwave generator, causes high-frequency electromagnetic field that is delivered to the target using an internally cooled antenna, which is just like radiofrequency ablation. That's how we use that as well. In laser ablation, a focused beam of light energy is generated by a diode and delivered via optical fibers, which are introduced under ultrasound guidance. Laser ablation delivers the lowest applied power and uses the thinnest of needles of all of the thermal ablation techniques, so it might be the best option for those who can't stop at any coagulation or who have other problems. And finally, we get to RFA. Like all of these techniques, RFA is outpatient. It's performed with just local anesthesia. It takes slightly longer than microwave and laser ablation. The high frequency alternating current causes ionic agitation, friction, and heat, and causes coagulant necrosis. The necrotic tissue is slowly autodigested by the body, and eventually the nodule shrinks, just as in microwave and laser ablation. The goal is to destroy the nodule itself while preserving all of the surrounding normal thyroid tissue. The image here shows the anatomic relationships of the relevant structures to the electrodes used for RFA. Using ultrasound guidance, an 18 or 19 gauge electrode is introduced in the nodule through the thyroid isthmus. Using the transisthmic approach, you can actually visualize the entire length of the electrode and therefore keep your eyes on the entire needle and make sure you're not going somewhere that you're not supposed to. It minimizes exposure of the heated tip to the critical structures, such as the recurrent laryngeal nerve and the esophagus. And additionally, because the electrode passes through the isthmus, which is an ample amount of thyroid tissue, if the patient's talking during the procedure or swallowing, the probe doesn't move and it's not really a danger for you to accidentally get it into tissue that you weren't planning to do. It also prevents, using the transisthmic approach, also prevents leakage of the ablated liquefied tissue, which decreases the risk of nodule rupture, which we'll talk about later. And then finally, the way this is delivered is using the moving shot technique. So the thyroid is conceptually divided into multiple small subunits, and the RFA is performed sequentially, unit by unit, moving the electrode tip. Hopefully this video will play. Nope. But it's okay, because you'll get it on this one. So this is what an ablation actually looks like. Wow, that does not look like a video, but that was really fun. Sorry guys, worked on mine. Imagine, if you will, so basically you pass the needle. Anyway, imagine you go in from the isthmus, you go all the way down to the most kind of posterior and lateral aspects first. And then as you start ablating, you start to see microablations. The tissue becomes more hyperechogenic. And as you see those changes, you also are getting feedback from the RF generator that tells you about the impedance in the tissue and tells you basically how cooked that part of the nodule is. And you slowly move it back, as you watch these microbubbles form. And when you get to the top kind of medial aspect of the nodule by the isthmus, then you go back, kind of fan forward and go out a little more superficial to where you were and a little more lateral, and keep doing that. So you do a whole subunit and then you move up and do the next unit of kind of the transverse sections that you're looking at under ultrasound. I'm sorry, my videos didn't work. It's really important that you do it in that order, because as these hyperechogenic changes happen, you can no longer see the probe in the nodule. So if you were to try to do posterior areas second, you wouldn't be able to see your needle tip, which is obviously a safety risk. Side effects include some pain and soreness, as well as possible transient thyroiditis. Major complications are similar to microwave and laser ablation. They include burn, hematoma, as well as thermal injury to just the nearby structures. Rarely delayed nodule rupture can occur, which is thought to be from disruption of the capsule of the thyroid, and extrusion of necrotic thyroid contents, which sounds disgusting and is. Haven't seen it yet. This presents with sudden neck swelling and severe pain. Crazily, it can happen 2 weeks to 3 months after the procedure. So you do have to kind of have this in the back of your mind if someone calls in after the procedure. That's treated with steroid tapers, and which decreases pain and swelling. Sometimes it requires antibiotics or aspiration, and there have been instances where people have had to take people to OR and IND. Importantly, RFA can interfere with pacemakers and ICDs, so it's a relative contribution to the procedure. All right. Did you know that orcas have the same lifespan as humans, and they can live up to 90 years? I did not know that. I thought that was crazy for such an enormous species. They're also one of the only species, including some other toothed whales and chimpanzees, that go through menopause. And scientists studying this, evolutionary scientists, think it's because the females live longer in order to pass on all the knowledge that they've gotten. So they teach how to use different dialects to communicate with other pods. They also teach hunting strategies and kind of encourage the survival of the younger generations. They also pass on things like how to sink really expensive yachts. If you've seen that in the news, that's happening a lot in the last couple of years, which I think is just crazy. And I've watched videos of it happening there. They're unbelievable that we can learn that. Okay, back to thyroids. Next, we're going to just review current indications and evidence supporting RFA. It's currently approved and widely used for benign thyroid nodules, including non-functioning and autonomously functioning nodules causing hyperthyroidism. The safety, there's growing evidence of the efficacy and safety in low-risk papillary thyroid cancer as well, but we'll start with benign nodules. Okay, benign non-functioning nodules represent the primary indication worldwide. Goals of treatment are volume reduction, symptom improvement, and improvement in the cosmetic appearance. Multiple meta-analyses and systematic reviews have been performed demonstrating a 50 to 85% mean volume reduction at 6 and 12 months. The most common way to measure volume reduction is using the volume reduction ratio. It's just the ratio of the residual volume over the initial volume. In order to determine candidacy for radiofrequency ablation, there has to be an evaluation of benignity of the nodule. So the guidelines recommend 2 benign biopsies, although if you get a Bethesda 3 or 4 biopsy result and do molecular testing to test for genetic mutations, as long as that's negative or low risk, you can also do this procedure. In the case of really low suspicion nodules, so on ultrasound TIRADS 1 or 2 nodules, you can consider doing this with just a single negative or a single benign biopsy result. That's a change from previously. And then the patients should also have thyroid testing to make sure that their thyroid function is normal. In this recent paper by Park, it provides long-term outcomes data for patients who underwent RFA for benign thyroid nodules. This is out of South Korea, where they first started doing this. So this is 421 consecutive patients treated with RFA for symptomatic benign thyroid nodules between March 2007 and December 2010. RFA was performed according to the standard protocol. Dang it, now the pictures aren't showing up. I wonder if this is just how I saved it on my Google Drive. Apologies, you don't get the graphs. So they followed the patients at 1, 6, and 12 months, and then yearly until August 2022. The volume reduction ratio was calculated each follow-up, and they also assessed for the incidence of regrowth, delayed surgery, and other complications. They also used the Kaplan-Meier method to assess and evaluate for the cumulative incidence of regrowth. Mean nodule volume was fairly small, 21 milliliters, plus or minus 23 mLs, while the median follow-up period was around 90 months. The mean reduction ratio was 81% at 2 years, 90% at 5 years, and 94% at 10 years. Overall regrowth was only noted in about 12% of patients, or 53 nodules. It was treated with repeat RFA in 33 of those, surgery in 4, or just left under observation in 16. You can't see from this Kaplan-Meier curve, but imagine it. Nodules that have really large volumes, over 20 mLs, are much more likely to have regrowth, a hazard ratio of 2.3. Regrowth was most commonly observed in the first 1 to 4 years after RFA, and then after 4 years, it's much, much rarer. Delayed surgery did end up being performed in 6% of patients, or 26 nodules. The median interval between RFA and surgery was over 7 years, however, and the reasons for surgery included regrowth or persistent symptoms in 4, and then newly detected thyroid tumors, 21 of which ended up being malignant. Oh, wow, you put them at the end, sure. So this is the first graph, and then this is the Kaplan-Meier graph. Yeah. Okay. So the largest series of North American patients was just published last year. This included 620 patients from 3 different institutions, and they had RFA between 2019 and 2022 with an average follow-up of 12 months. The patient population was skewed to a slightly smaller nodule size than the last study. The BRR in this case at 6 and 12 months was 65 and 71%, which is good, not as good as the Korean study, which may just reflect a difference in experience over time. During the study, a total of 20 complications occurred, a complication rate of 3.2%. The most common complication is acute voice change that happened in 14 patients, but all of them were followed post-procedurally and all had normal laryngoscopy with normal vocal cord function after the procedure. 3 instances of suspected nodule rupture occurred, with one actually spontaneously draining through the skin, colloid debris. And then each was treated with a combination of antibiotic and steroid therapy without any further infectious issues. And then 4 patients ended up getting hypothyroidism, which is pretty. All of the cues are out of order. Apologies. So next we're going to look at RFA and the use of autonomously functioning thyroid nodules, or AFTNs, which cause hyperthyroidism. This is a subset of hyperthyroidism. Only in about 3 to 5% of hyperthyroidism is caused by a toxic adenoma. They're usually treated with antithyroid medicines prior to definitive therapy with radioactive iodine or surgery. That picture in the top right is a radioactive iodine uptake scan, and it shows just one really hot nodule. And it correlates with this ultrasound finding of this large nodule in the left lobe of the thyroid. RFA can improve thyroid function with normalization of TSH in 40 to 70% of patients, eliminating the need for more traditional definitive therapies in this population. Results aren't immediate and has been found to be more effective in small nodules. It's critical that almost all of the nodule is actually ablated because any residual tissue that's unablated can cause hyperthyroidism, just like if we don't take out a pyramidal lobe in Graves' disease, we can still develop hyperthyroidism from just a little bit of tissue. It's less disruptive to patients planning for pregnancy and has reduced risk of frank hypothyroidism than lobectomy or radioactive iodine. However, both RAI and surgery have higher success rates classically. In order to determine candidacy, again, we have to evaluate for benignity. Given hot nodules are really rarely malignant, you only need 1 benign biopsy, or Bethesda 3 or 4 biopsy result with negative molecular testing. Graves' disease should be ruled out because that's not currently an indication for RFA. And a radioactive iodine scan should be done just to confirm the nodule that you're going to treat will actually treat the hyperthyroidism if that's what we're targeting. This is a retrospective study published last year from a multi-center group in Latin America. It studies the outcomes for AFTNs. It involved 81 patients with solitary hot nodules with a single session of RFA. They found a median VRR at 1, 3, 6, and 12 months of 50, 74.9, 78.4, and 90.2% reductions noted in those time periods. 93.8% of those patients actually had resolution of their hyperthyroidism as well. TSH normalized by 1 month after the procedure in 58%, and another 33% having normalized by 3 months after the ablation, which is fairly common if you give radioactive iodine, it takes about 6 to 8 weeks to get that resolution of symptoms or hyperthyroidism as well, unlike surgery, which is immediate. Although they had some larger nodules in their study, they didn't find any difference in nodule size correlating with treatment success. But a lot of the nodules were smaller, with a median thyroid nodule of 6 milliliters and as little as 0.5 milliliters, which is teeny tiny. On bivariate analysis, volume reduction ratio over 50% at 6 months was correlated with resolution of hyperthyroidism. They did have a high complication rate of 6%. 1 had transient Horner's, 3 had voice changes, and then a single patient ended up needing hypothyroid or was hypothyroid. RFA and other interventional techniques have now been emerging, as I said, to treat low-risk papillary thyroid carcinoma, or even for episodes of recurrent cancer after prior surgery. So T1 tumors are those under 2 centimeters, and T1A tumors are under 1 centimeter. Traditionally, nodules less than 1 centimeter aren't ever even biopsied when we see them on ultrasound. So these patients, should they be biopsied and have confirmed papillary thyroid cancer, have classically been offered either surgery or active surveillance, which we talked about earlier. But there have now been multiple prospective studies assessing the efficacy of RFA for treatment of these nodules in this population and they found comparable local control with lower morbidity than surgery. Predictors of success include small lesions, at least 2 millimeters from the thyroid capsule. And then the reason that this is important to think about, it's a good idea in some patients who are younger. And the reason is that younger patients are going to have a longer time in active surveillance if they choose to watch their thyroid cancer. So they're therefore more likely to have disease progression at some point along their course, unlike an elderly person who joins active surveillance and only lives another 5 to 10 years. New ATA guidelines do state that RFA can be safely used, particularly for patients who refuse or are too unwell for surgery. This can be used for T1 tumors under a centimeter, but it actually has been expanded to T1B tumors as well, up to 2 centimeters. And then when counseling patients, you just have to understand the shortcomings of RFA in the treatment of thyroid cancer. And that's kind of summarized in this slide. The American Thyroid Association and the NCCN highlight that surgery provides definitive treatment, allows for histopathologic diagnosis and assessment of margins, which radiofrequency ablation obviously cannot do. But RFA does offer outpatient management, low morbidity, and preservation of thyroid function in a safe environment for them to have this treatment. Patient selection and shared decision-making is really important in interventional thyroidology. So the decision to pursue minimally invasive thyroid treatment versus surgery is patient-specific. It has to be shared between the patient and the physician. So let's take this picture. This is a woman with a clearly visible right thyroid nodule. She's evaluated after having long-term slow growth of this nodule with worsening compressive symptoms of globus and dysphagia. She also has worsening cosmesis. Now her friends and even strangers are commenting on the growth on her neck. So first, as a physician offering this, you have to determine if the nodule is amenable to RFA. So assess the thyroid ultrasound, ensure there are no high-risk features of the nodule and that it lies in an area that's safe to deliver thermal energy. Then you have to make sure that they've had their appropriate diagnostic workup. And then you have to make sure that the nodule actually correlates with the symptoms that the patient's trying to treat. So I've absolutely had patients complain about large thyroids and how bad it makes their neck look, and they're pointing at a fat roll on their neck. And I can't make that better with surgery or RFA without the help of a plastic surgeon. So that is not the right person to say, yes, I can make it better. Importantly, really small thyroid nodules under 1.5 centimeters, highly unlikely to be causing compressive symptoms. So you have to be honest about whether or not you can make the symptoms go away or whether you even think the thyroid is the cause of those symptoms. Occasionally, this requires additional studies to see if something like dysphagia really can be coming from this. So in this example, this nodule is pushing in, this is a barium study, pushing in on the esophagus, and you can see extrinsic compression from the cervical thyroid there. That patient, you're going to feel pretty good that you can make them better with either surgery or RFA if you can get that nodule to shrink down. And then additionally, some nodules aren't great to ablate for the opposite reason. Really large nodules can take multiple sessions, and to get meaningful improvement in symptoms, you just have to prepare them that this might be a multi-course study for them in order to get their under control. Once you've decided if it's feasible and you can make a meaningful difference, if it's successful, then you have to define what their priorities are. So maybe all they care about is the cosmesis. They just don't want a scar. So a little bit of nodule shrinkage is going to go a long way for that person. Maybe they're just terrified of surgery in general, and they just want it to be a little smaller so they don't have to worry about it anymore. Some are really adamant that they don't want surgery because they don't want to be on thyroid hormone, they don't want to gain weight, they don't want any medication to take. All of those things favor RFA, but they're not always the best thing for them. So you just have to work through that with them to address all of their symptoms. That was if they choose RFA, they have to know that while it's not a cure, it can have dramatic results. So many are happy even if it's still present or it requires multiple kind of interventions and follow-up afterwards. You can see she had a really good response to an RFA. That nodule is almost certainly still there on ultrasound, but you can't see it as well. This slide summarizes the use of RFA for 3 major societies guidelines, including the European Thyroid Association, Korean Thyroid Society for Thyroid Radiology, and the ATA. All 3 agree on indications for benign nodules, as well as the basic pre-procedure workup, contraindications, and technique. Where they disagree is just that the European Thyroid Association and the Korean one support RFA only in C or clinical T1A tumors, so under 1 centimeter, while the ATA now allows for RFA and up to T1B or 2 centimeter nodules. There are many areas for growth. There are many areas for growth in the use of RFA. One area is Graves, where pilot studies have shown that you can have induction of remission in persistent or relapsed Graves patients, with 73 to 79% of patients euthyroid or hypothyroid 6 to 12 months after RFA. That's a lot better results than I would have expected for having to ablate an entire thyroid in order to get those results. In multinodular goiter, studies report mean volume reduction rates of 80 to 85%, a significant improvement in symptoms. These are the patients that are ripe for counseling to say you're going to need staged procedures. You can't do all of the nodules at once, but they can have really good successes if they are willing to take on multiple procedures. In the pediatric world, interventional thyroidology has also been used with appropriate volume reduction and low complication rates. It's obviously attractive for children to not have to undergo surgery for benign nodules. And then there's also evidence that combining RFA with either ethanol ablation or systemic therapy like kinase inhibitors, RET inhibitors, or immunotherapy can treat recurrent metastatic RAR refractory disease, even when surgery is not.
Hey there, it's Shamika.
Protocols haven't been established yet.
Is Apple's today is an essential need.
This was supposed to be before that slide, but this is just a picture of an eye I liked, probably because it reminds me of Dr. Tachi Leon on trauma rants. But did you know that owls don't have eyeballs? They have eye tubes, and they're completely fixed within their skull. They maximize light intake, so they get really excellent night vision, excellent depth perception, which is all critical for their hunting ability. But because they don't move, they have to be able to rotate their heads a lot. They can rotate their heads 270 degrees. All right. I wanted to just cover a few other areas where I could see this procedure growing in the future. So first, the technology around RFA is almost certainly going to grow in the short term and the long term. There's room for device innovations, including improved electrode design and real-time thermal monitoring of the surrounding tissue while you're doing the procedure. There's the use of nanosecond pulsed field ablation has been investigated in other fields and is promising in that it delivers rapid, high voltage electrical pulses to trigger programmed cell death via a non-thermal effect. Importantly, it preserves non-cellular structures like nerves, which would be really critical for someone like me who worries about those in these procedures. So I really look forward to seeing if this procedure can be used for our nodules. There's also opportunity to bridge RFA with AI work to allow for ultrasound-based decision-making, ablation planning in the pre-procedural time, and then during the procedure using real-time guidance or mapping more precise ablations during the procedure. And then finally, there's growing use of modalities outside just our basic ultrasound to assess for how we did with our RFA and how much viable remnant did we leave behind. Contrast-enhanced ultrasound provides improved imaging by using contrast, and it highlights which areas are still vascularized and viable within the nodule. And then there is something called elastography, which can be used to measure the stiffness of the tissue. So really soft tissue is probably necrotic, whereas more firm tissue is viable and probably needs more ablation. And then lastly, I just wanted to go over what you need to keep in mind if you're a resident seeing the patients afterwards. So first, RFA is going to change the echogenicity of these nodules. So they are going to look scary on ultrasound. They'll be hypoechoic, they'll have irregular borders, they'll look like they have microcalcifications in them, all the things that you would say, this needs a biopsy, this looks like capillary thyroid cancer. But if they had an RFA, that can be and probably is normal. If a patient ever calls you or is examined by you and has severe pain, erythema, local swelling, you've got to work them up like something terrible could have happened. Could they have a tracheal injury or an esophageal injury? Could they have other soft tissue infection. You're going to need to get them some kind of imaging, at least an ultrasound. Often they're going to need cross-sectional imaging and potentially other things like a swallow study or bronchoscopy to evaluate those other structures. Hoarseness can happen. It's not always an emergency, just like after thyroid surgery. So if they are not aspirating, if they are able to breathe and do their normal activities, they can come see us in the clinic the very next appointment because we do those procedures in the clinic. Obviously, if they're having difficulty breathing, we are. And then let's see what else. Nodule rupture we talked about. That should be something you're suspicious of all the way up to 3 months after the procedure. So someone calls and says, I had my RFA 2 months ago. Don't just write it off. Like, who cares? Your neck's probably not hurting from the procedure that long ago because it really could be related to this. And then looking at follow-up, most of these are just kind of recommendations. I see people back at 6 weeks, 6 months, and 12 months in the beginning. Monitor their thyroid function test, so I make sure they're not hypothyroid afterwards. Do an ultrasound to assess for the volume reduction ratio and if there any evidence of regrowth. And then I haven't done any autonomously functioning nodules, but they need more detailed follow-up of their TFTs so that you can see if they can come off their antibiotics. This is just a summary of when to refer patients for this. And otherwise, I think the only thing we need to keep in mind is that although these procedures are quick and easy, the results aren't that quick. So we do have to counsel patients this takes time, and if they have severe symptoms now, surgery is probably going to be the better option for them. So referring patients early when they start to have symptoms from thyroid pathology is recommended, so they can at least have this in their head as a possible. Well, that's it.
Thank you. I have great talk, and as usual, it's wonderful, even though you expressed your doubt on the topic. You've done great work in getting this program set up, and obviously the number of patients ultimately you've been able to treat with these approaches is limited. Two things. One, can you comment on the volume of patients you see who are here in part to consider RFA and how that may have impacted sort of referring physicians and referrals to us? And then the other thing is, this is a procedure with an FDA-approved product, relatively low resource needs. It seems like a slam dunk, just we'll get it in, we'll get it going. Can you comment a little bit about some of the challenges you encountered in getting this up and running despite that, those facts?
Yeah, so I mean, in terms of referrals, it's really still in its young enough phase that not everyone knows it exists. So I would say probably 3 or 4 patients a month come in having read about it, asked about it, or referred specifically to talk about it. Of those people, it's nice as a surgeon. I think it's really important to be a surgeon offering this because you can talk about all of the options. And so I've had many people want it and then hear all about it and say, well, I don't want to be followed forever. No, just take it out. And that's okay. I try to encourage them to at least consider it, but I'm not going to push it as a surgeon because we can do other things for them. I think when you are an endocrinologist or IR, and that's the only thing you can offer, the push is a little harder, which makes me worried about those what those patients are hearing counseling wise about surgery. In terms of getting this started, yeah, it's kind of crazy how much you have to go through, especially given that I had someone here before me, an IR doctor who was doing it. The amount of hoops we had to jump through to get it approved by UVA was surprising. And that has been echoed by everyone I know who has started these programs elsewhere. So we're not alone. I think having it FDA approved, having a CPT code, having a kind of uniform way to go about doing this has made this a lot easier because we had to kind of make that up from scratch and say, okay, this is what we're going to charge. This is what the facility fee will be. This is what the RVUs will be. But now that's sort of a little bit more sussed out. So it's easier for the next series of people to start on these programs.
What's been your process for sort of spreading the word on this to the endocrinologists who are referring to you, to the primary care doctors? What's your process for, I mean, this is the first time I'm hearing about it. imagine that folks who are referring to you have heard about it a little bit more. What's your process for making it known that this is a service that you offer?
Yeah, I think I can do a lot better with that. But when I first came here, this is a means of kind of getting to know the providers in the area. I went around to all sorts of offices doing outreach first, which I think is important, just building your own practice for those of you who are going to have to do that one day. But it's also important, as when I was recruited here, this was a goal, setting up an RFA program and making this happen. And so I mentioned that everywhere I went, told them why we would use it, told them what the kind of benefits for using it are. I think it's generator company that we use, StarMed, also has a really good support system in terms of having flyers that they can send out with my face on it, my office's number, but it's kind of pre-approved material that they send about all of their physicians who can provide it, and they can send it to all my referring physicians. I think probably where I'm lacking is I'm not sure all those people that I met 3 years ago know about this now. So that is one thing that I just reached out to them about 2 weeks ago to really kind of engage them in sending this to more people so they know that it exists. But there's tons of PCPs that I could not have met, and they don't know that this is an option even for their patients in the area.
You mentioned that some centers do this for nodules, specifically BTC. Typically, at least in liver ablation, the recurrence is frequently at the deep margin. What are the surgical considerations for reoperating on these patients?
That's a good question. I obviously have not, well, not obviously, I have not reoperated on any of my patients, but from what I'm told, this really has not been a big issue for patients who had to move on to surgery, either from failure to resolve their symptoms or they didn't want to do a repeat procedure. Obviously, if you had like a nodule rupture or some kind of catastrophic issue, that's a bigger deal. A lot of patients where you could imagine that being a lot harder, if you ablated a really posterior nodule near the recurrent laryngeal nerve, that those are people that you probably would have rejected to begin with, say this is too close, I'm not comfortable. But I could imagine that scarring in that area would be a lot harder to deal with, but I think most of us would sort of avoid that area.
Yeah, great talk. And we were talking about this morning that we're about to start recruiting season, and you're just another great example of a product that we produce and forward to the recruiting season, just trying to do the next hand up Fashandi. So how did you, first of all, did you learn this in fellowship? And then how did you make the decision that I've just finished my training, I've just done all this work, and now I got to learn something new? And how did that feel? And how does it feel as you're kind of going through something, as you adapt to a new technology that you're comfortable at first?
Yeah,
I love that process.
I think, so to answer the question about Michigan, no. But when I got there, they were like, we're setting this up, you're going to be doing this, it's going to be great. Couldn't get it approved the whole time I was there. Couldn't get it approved the next year after I was there. So they started a year and a half after I left. Not the fastest thing to set up. In terms of like getting started and being comfortable operating on my own and now saying, just kidding, let's do a whole new thing we never learned before. I learned it by going to a couple courses that included a hands-on experience. Now, the hands-on experience is literally cooking meatballs in a gelatinous substance. So it's not in any way related to taking care of the patient, obviously. But it does give you kind of the hand-eye coordination to do it. I didn't, I think the hardest part about starting something new was having that conversation with the patient and saying, just so you know, I haven't done a lot of these because they all are going to ask how many you do, and obviously I'm not going to lie. I think a lot about, I can remember Dr. Shermer telling us like about endoscopic myotomies, being like, well, if we're not doing it, then we're missing the boat. So that's sort of how I approach it. Like I can't just let the opportunity pass, even though it's not comfortable. And you just have to be honest with your patients. My very first patient, I love her. She was just like, yeah, I know I'm your guinea pig. This is gonna be great. And you just have to kind of find those patients who are willing to avoid surgery and try something new, knowing that you are going to do everything you can to keep them safe. But it is uncomfortable for sure.
So awesome job with this. This really took a lot of effort from your part, lots of meetings, lots of creativity, lots of persistence in terms of getting it set up and how you're going to bill for it. And so great job navigating through all of that. Looking forward to seeing the growth of this program, and all of us get imaging on our patients for follow-up, and it seems like about half of patients have something in their thyroid. So we will keep you in mind, and
Absolutely. And every once in a while you get the weird things like, I had someone with renal cell carcinoma in their thyroid. So sometimes it really is relevant to the oncologists out there.
Well, it's very a pleasure having you in our department. I think the residents can say that, your passion for education, continues on. I think for the residents, it's, we talked about it or we mentioned it here. It's a very impressive what she's done, being able to start as a junior faculty, getting her practice going, but at the same time, starting a new program like that. I think, I think it was Charlie's question. I mean, this is very difficult and it took a lot of time and effort. So congratulations on that. But really looking forward to, having this program grow, having you seen us to the leader and, building this program as well. Thanks a lot, Anna.
Thank you. Thank you, Anna. It always happens. And I always am like, what? I didn't look at
Exploration, there's and then snowball. Persona shows carcinoid.
Okay.
Good. I was in that meeting the other day and I think I sent an email. Is it okay if I join operation on a meeting if we still have No worries. I totally understand. Oh, that's after time. Oh. Yeah, so,
She's metastatic disease.
no, shows nothing.
Oh, okay.
Yeah, I'm gonna do because big hernia, recurrent hernia here
Yeah.
is causing pain. That's why she come to me. So, you gonna go?
Oh, either way.
Yeah, so you go to UVA or not?
No.
Oh, no, okay. So still has diarrhea. Do I need to do some more examination to see, or just go like the way it's done?
Did she get a dotatate PET scan?
I think she has been found by.
I think if there's nothing,
She only has some diarrhea 2 to 3 times a
the
day.
diarrhea is from, but that's odd. There might be lymph node disease.
Yeah, she has no flushing. There's no.
I think if there's nothing on scans
Yeah.
and med-onc doesn't feel like there's any metastatic disease, then it's
Right.
not a big deal to proceed.
Okay. So yeah, that's why I saw.
But
since she's
if you're worried
found
about metastatic disease, then I would get a dotatate.
But I told her I may stop if I get in and found there's a tumor everywhere. I will stop.
Yeah, do you wanna send me her MRN on Epic? I can take a look and see if there's any red flags.
Okay.
Great.
Yeah.
Thank you.
Better. And then apropos for today, the mismatch. Refer to patient Nobody. They're working on robotic clock. We don't know. You and I not knowing, but the medicals are not knowing. That's yeah, well, and they don't think like how to prevent center. Like, yeah, we're asked to put it on. But it's unclear. Workday and like this is not a huge issue of, this is, okay, that's fine.
Little as possible.
They're talking about combining the Vador committee and the
So you can
outpatient.
spend money.
Right, yeah,
You don't
and-
spend
and
money.
she's gonna save me a ton of time.
Yeah.
That's the thing.
Probably.
Okay.
Already.
I'm gonna take a high tech.
Yeah.
And so, yeah, I had read about that.
That's good, thanks for, I should call it.
Oh,
Yeah, so it's.
So two things, one was, there's a lot more,
The only billing for it right now is the diagnostic box, but. But
You can't do like a high tech.
Yeah.
32, yeah. So,
But,
I think it's there, and you and I want to practice.
So like the ones who
So
don't
you-
get.
Especially the same thing, is also, they want like special.
High pressure. Trying to
They're talking to
basically get
Consumer 32. That's a meaning for, that our department has to give a move.
I remember actually.
Totally. No, I know that, of course, like, she said, like, well, you can give it to them, but that, you have to find a room within our department. It's like,
Germany, that's who started it.
no,
In the first trial in the US.
They want to appease them through an overall
High-tech.
institutional thing, everybody chips in.
yeah. We cannot take it from, we have, we are much more utilized, we utilize our.
Everything else. Like reading
Well,
here and there.
Yeah.
I analyzed the data
And then you can kind of figure out,
from
all right, where is it?
Yeah, sure.
Yeah, and I'll put all the data perspective in my database.
They're utilizing the 4-block room much more efficiently. They've actually,
I have friends who are
on Friday,
not.
they somehow leverage our 15
I think-
J. So they're within
Yeah, which I'm okay with, yeah.
their confines, they're making it. There's some griping about the 12-hour
Rounds into
room.
it and Island. I think there's
How is it?
Cardiac 12-hour room.
still deciding. I think I would start with the safe things, right, like unresected. But mostly unresected.
So you look at
Right
national,
now, people who don't want to high tech, but don't wait long. I try.
so I think that's.
People are like.
My editorial, they're resistant to looking at
Patients that get tumor sites.
Everyone just has to be honest.
Like,
and
like,
just-
what would it maybe
That's one of my
like
questions
stop
for the
and
board
site?
next.
I,
You know,
I do know
like,
Kern is sending
high tech for
emails to.
like, try and use it. But the question is, if I have to ask all the other boards if
Yeah.
they need it.
I know they go beyond me and you and stuff, but that's just why.
Maybe it's.
They didn't want to deal with it either. Like,
Well, then they should,
But it-
they should stop that, they should stop that communication. And when I had a private conversation.
That would be, yeah.
Once
You would add some like that.
I bet you're, incoming, is it August?
August, yeah, sure.
Yeah.
Okay. Yeah, he was on vacation when I was down in
Yeah,
Galveston.
he said that, yeah. He mentioned that. He said that.
Like to be on the ground floor of that, so that when people are providing databases.
Yes.
Where else is?
Okay, good. Okay. You seem all happy at the college, so I didn't ask him anything.
He's, the impression I got from that is he's
UVA offers.
meeting expectations that both Tracy and I said
My first step,
I talked to Sean, about the ACS surgeon.
Okay.
If you're interested, let me know. Oh,
Okay. Yeah, it was either that one, there's something at Harvard, but it's a year old.
Yeah, no, yeah. George, back
Oh.
in, yeah, so he's talking about it in college.
No, now it's the time because I have lots of friends who are starting it up with their.
Yeah.
And, you know, you combine all the data, actual flow data, part of that. So I'm officially trying up for the course. Supporting you, I'm gonna be.
And you come up with, trying to do an adenoviral gene therapy with it, right? Imagine all of that.
Yeah, no, exactly. Very, and I heard. I'm actually going to not anyone I see. It is, you know,
I have your service database, yes.
so it's not just high tech, because then I can have a comparison before.
Right. But you can go back and say, actually, here's a bunch of patients we didn't do IPEC on these would be good candidates. Let's call them and see.
Yeah, this would be, I know it's hard, it would be nice, like, I can't do high tech. Try high tech, more. Step in the back.
That's right. Right.
Yeah, a lot of people I say no to are like 40, 50.
That's great.
Oh, tell me what happened.
Adam. Actually, I'll-
Yeah,
I'll-
no, I'm gonna go. I just-
All right.
Alright,
Thanks.
Committee this morning. I think we should. Let's do that. I would realize. I just want to see. On fluid. I'll circle back. They're gonna show us. From that area.
From that area.
And showing like how much, like, you know, people were like, she's so busy here that she's not moving. But they don't want to move it. Patients are here, but there because of multiple patients coming in. Well, we have help with practice. Right, if it's scheduled, never, yeah. Can't get in surgery here until February, but we can get in there. I don't even know how the contract works. So I'm sure it's like renting the space, right? You pay for time. Years. Right? Like, I'm not gonna run a piece of money. You don't see that. You always have to let you go and say, hey, I want like, you know, want. So, right? Yeah. Especially at a private.
I don't know how they, I don't know how that business reached. Right.